Health Minister Sussan Ley has arrived, and I know her time is precious. So we might just keep the panel here, staying here. But if we might ask Health Minister Sussan Ley, who's here representing the Prime Minister, to come and talk to us, which would be great, and then we can resume our discussion afterwards. So please welcome Sussan Ley.
Thank you, Sophie. It's lovely to be here, indeed representing the Prime Minister, who sends his apologies. I know that bells may ring at any second, and I don't want to cover ground that you as the experts in heart disease already know about. But I was alarmed when, in preparing for today, I looked at the statistics, and they've told me around 4.2 million Australians are affected by cardiovascular disease. That's 18% of the population. Over half of all cardiovascular deaths involve women, and of course it rivals cancer as our biggest cause of death. As is the case with other chronic diseases, Aboriginal and Torres Strait Islander people are overrepresented, and 1 in 4 Indigenous adults aged 18 and over have some form of the disease, and 3/5 of those are female. So that tells me this is a massive public health issue for every single Australian. I don't think she'd mind me mentioning this, and she's no longer a senator in the Parliament, but Senator Sue Boyce was a Queensland senator, and she didn't come to Parliament for a little while, and I asked her what had happened, and she said she'd had a heart attack. And she was back on her feet, and that was good. But when she described to me how she hadn't had any idea that it was a heart attack, she'd woken in the middle of the night and she thought she had a stomach bug, she'd gone to the toilet, she felt a really upset tummy, she just had no idea. At no stage did anything even feel as if it was squeezing her heart muscle. And I know that when I wasn't Health Minister, when I heard that story, really put a red flag in my mind about one of the things that we absolutely have to do around awareness. So I see the health portfolio's responsibilities here, I suppose, in two segments: prior to a heart attack happening in someone, and then what we do after that. Prior to a heart attack occurring, awareness has got to be incredibly high on our list, and these sorts of events help that, and I thank you for that. The social determinants of health, particularly in Indigenous populations, are something that we do need to address, and we are addressing through the various Indigenous Australians' health plans, but social determinants can't be turned around even in a generation, so we must continue to work hard in that area. Research is important, and the research that has gone into cardiovascular conditions has been significant. I think it's been 1.2 billion in about the last 10 years through the NHMRC, but I also know the competition for the research dollar is pretty tight. Sometimes the research dollars don't necessarily land in proportion to the toll that a particular condition takes in a community. Having said that, I'm hands off with the decisions about where grants go, and they all go to very good causes. So thankfully, we've got the Medical Research Future Fund coming online even as we speak, with about 800 million over the forward estimates, and that fund, separately from the NHMRC account, will disperse $1 billion a year by about 2021 or 2. So that's really an enormous effort around research, and I know that some of the, not just the treatments and causes of cardiovascular disease, but also the best methods of treatment in terms of how we approach that awareness and that treatment. It's incredible that when you do hear the stories and you do realise how overlooked cardiovascular disease is in women, and we have as our main reform, if you like, in primary care, our healthcare homes. And I would hope that management inside the healthcare home would not make a cardiovascular condition pop out of nowhere for many of the women involved. This particular reform is all about bringing patients in closer connection with their usual doctor at their usual general practice. If we look back to how the medical system ran in my grandmother's day, or even my mother's day, it was very much your usual GP who knew you from cradle to grave, who understood your circumstances and that of your family, and you were well looked after. You're still well looked after in the health system, but it's very much intervention by intervention, often specialist intervention by intervention. So that continuity, particularly in the primary care phase, is tending not to be there as well as it could be. So by bringing healthcare homes as I said, as our major reform, what we are going to do is say for the top 25, to start with, the top 25% of patients with chronic and complex conditions, your doctor will be remunerated differently, quarterly bundled payments rather than the transactional Medicare system that we see now, to look after you as the whole person with all of your chronic and complex conditions. And that will cover activities that are preventative, that are outside 9 to 5, and that are innovative. So it's not simply, well, the doors are open here, the doors close here, and Medicare clips a ticket in between. It's far more innovative and really exciting. And the key, there's lots about the provider side of healthcare homes, but one of the key ingredients of the model, and when you look at overseas, this is certainly really vital, is that the patient, the individual, takes on a lot of the responsibility themselves, because unless they do, they become sort of passive recipients of a system. They can't necessarily judge how good the system is, and maybe they never will, but unless they get interested and engaged, it won't work. So that interest and engagement in your own health is an often overlooked but key plank of our healthcare homes model. And clearly, when it comes to the other thing that you can do before a heart attack strikes, which is diet, exercise, and lifestyle, it's vital as well. Given the propensity for the obesity to manifest itself so much in females, we recently launched an advertising campaign late last year called Girls Make Your Move. It was aimed at girls in the early years of high school. We do very well in getting sports and activity into schools in primary school, and that's compared to international indicators pretty good. But when girls move to the early years of high school, they slow right down, and often they don't get back into a regular form of exercise. So our sporting schools program links them with a club and a coach, so they don't just do things like running around the oval and and throwing bean bags, which was the predecessor to that program. They actually learn skills, not drills. So they learn how to play a game, they get excellent coaching, and they get a club that's in their area that they become connected to. Now, the important thing about this is that it gives them the lifetime connection, we hope, with that sport, with that club. They move away, they go to university, they know how to play netball, they know how to play soccer, they can join the club, they know how to do it reasonably well so they don't get, dispirited in the first game and go home, and the activity continues. So our Girls Make Your Move campaign has been incredibly successful. And I have to say, part of its success, and I went to watch some of the first filmings of it, and all the girls were beautiful. They all looked perfect, and they all looked as if they certainly didn't need to hear this message. So I said to the people who made the film, none of those girls need to be in it. You need to find ordinary girls. You need to find girls who looked like my daughters, who looked, God help them, like I did at school. You need to find real people. And they did, and actually the campaign's been an enormous success for that reason. Now, when it comes to nutrition, diet and obesity, it's easy to talk about, it's very hard to do. My personal view is that interventions that, happen later in life don't work very well. I remember speaking to an obesity specialist recently who said, the determinants are formed in utero and almost in the first couple of years of life. And after that, the trajectory is set, which is, should make us all really determined to do something for mothers, pregnant mothers, and babies, and that's absolutely where a lot of our campaigns around public health, particularly in Indigenous communities, are going, because it's just so miserable and unfair to tackle the adult later in life and almost accuse them of not doing things right, when in fact their circumstances are not the circumstances that we would imagine in our own lives, and therefore we should never make those judgments. So I'm delighted at the partnership that government and the health portfolio has with the medical profession when it comes to the treatment, the care, and certainly the preventative aspects of chronic disease generally and cardiovascular disease with reference to today. So thanks, Sophie, for the opportunity.